everyone, and thank you for joining the Iowa and the Minnesota chapter fellow education lecture series, imaging lectures. Um, Good evening to everybody again. This is Dr. Ashwath. I'm the governor for the Iowa chapter of the ACC. And it is my pleasure to introduce our fellow for this evening who's going to be presenting, William Parker. William is a first year fellow at the University of Iowa, and he is going to be talking to us about hypertrophic cardiomyopathy. William is originally from Birmingham, Alabama, and he did his med school at the University of South Alabama College of Medicine. He then did his residency at the Cleveland Clinic Foundation and is currently doing his cardiology fellowship with us. He is at the University of Iowa. His interest is, as of now, is in critical care, cardiac critical care, but we'll see where it goes. And a fun fact about him is he really enjoys cultural geography and can name at least one interesting fact about most countries around the globe. So if you have time at the end and you don't know what to do, so then you know what to ask him about. But he's going to be talking to us about hypertrophic cardiomyopathy, and I will let William take over from here.
Yeah, thank you for the introduction, Dr. Ashwath. I appreciate it. So give me a second to get screen sharing up, and then I will dive in. All right. So again, thank you all for joining. Today, I am going to talk about hypertrophic cardiomyopathy, which is, I think, one of my favorite diseases because it just spans kind of all the corners of cardiology, from valvular disease, structural, to electrical disease and ischemic. And so I think it has a lot of applied physiology that it's nice to be challenged to think about in a little more depth. Not to mention that it's a board favorite, so it's always good to brush up. I have no disclosures, and the one disclaimer I will say is, this is really meant for as a lecture for general cardiology fellows such as myself. Certainly there are heart failure specialists, imaging specialists, and even people who do one-year fellowships specifically in hypertrophic cardiomyopathy who could give you a wealth more of knowledge than I have to offer. But this is meant to be a comprehensive yet kind of easily wrapped up summary of the things you need to know. A lot of the information comes from this wonderful textbook, Manual of Cardiovascular Medicine by Drs. Griffin and Menon at the Cleveland Clinic, as well as the 2020 guidelines published by AJ and ACC for management of hypertrophic cardiomyopathy. I'm going to start by going over a case. There's a 59-year-old lady who came into the emergency department for acute onset chest discomfort. She was in her normal state of health until 1.5 weeks ago when she developed COVID pneumonia, but not requiring any medical therapy, and overall seemed to recover from it. Over the last 3 hours, developed shortness of breath progressively, and is now experiencing chest discomfort for the last half hour. She feels lightheaded. The pain radiates to her left neck, left arm. It's not sharp nor dull, not related to exertion. In short, she's a very healthy lady who has a very minimal past medical history, and not too much stands out. She exercises every day, and she is a criminal prosecutor. Really cool patient. Physical exam for her, she's hypertensive, and she has 2 out of 6 hollow systolic murmur heard throughout the precordium. Otherwise, normal physical exam. And labs, essentially normal. High sensitivity tropes took a little bit of a bump, and the third one is pending, but not back yet. Chest x-ray, this is an AP film, but still probably some cardiomegaly and perhaps the tiniest bit of pulmonary vascular cephalization. EKG for her, shows some very small inferior Q waves. And what I would probably say, not knowing clinical context or anything, is early repolarization. So, she came in looking not that well, but she was conversive. Then she had 2 episodes of emesis. The chest pain returned much worse. She became hypotensive and tachycardic, desaturated from, not requiring any oxygen to 5 liters nasal cannula. And then curiously, over the next hour, as she sat waiting for a bed in the an ICU bed in the ED, she kind of spontaneously got better. The ED did a point of care echo, which commented on severe MR, but no other pathology. These are some of our echoes for her. You'll have to forgive me. I had a little difficulty importing videos, so the echoes are a little few and far between. But regardless, this is the parasternal long axis, and you can see very obviously hypertrophied left ventricle, particularly the apical septum. Here, I'm not sure if the frame rate is really allowing you to catch it, but there's like a small amount of systolic anterior motion, or the anterior mitral valve leaflet kind of crashing towards the septum in systole. She didn't have amazing apical windows, but you can kind of see the endocardial border, and essentially you can conclude that her LV cavity is quite small. And we looked at the LVOT pressure gradient, which is, to an extent how you define severity of hypertrophic cardiomyopathy. At rest, she had a pressure gradient of 44. Which already qualifies her above 30. But with Valsalva, she had an almost unbelievable number, to the point where we later did a left heart cath to kind of invasively confirm. Pressure gradient of 173. She was admitted to our ICU, bolused 3 liters of crystalloid, and started on a phenylephrine drip to support her hemodynamics, and really within 1 day kind of turned around and was started on low-dose metoprolol. I'm going to talk about her a little bit later in the presentation, so just keep her in mind as I go through these next slides. So the next 15 slides or so are going to be kind of background stuff, less actionable information, but stuff you should understand regardless. Hypertrophic cardiomyopathy is defined as the presence of LV hypertrophy in a non-dilated left ventricle in absence of cardiac or systemic disease, which would otherwise explain that hypertrophy. Historically, there have been a lot of names for it: idiopathic hypertrophic subaortic stenosis, hypertrophic obstructive cardiomyopathy, which I think, or HOCM, which I think is still very popularly used, and muscular subaortic stenosis. The World Health Organization actually recommends against using those terms, and recommends the unifying term of hypertrophic cardiomyopathy, because it doesn't include obstruction, and obstruction is not necessarily required for the disease. So how do you go looking for a patient with hypertrophic cardiomyopathy? First, they are pretty common. The numbers are a little, there's a range, but 1 in 200 people to 1 in 500 people. So, you probably pass by at least one person with hypertrophic cardiomyopathy per day. It is a leading cause of sudden death in athletes age 35. Above that age, you're a little more protected against sudden cardiac death. And histology shows essentially disorganized cytoarchitecture and fibrosis. Most common site for for the hypertrophy is the septum, but that is not necessary for the diagnosis of hypertrophic cardiomyopathy. And focal hypertrophy can really happen anywhere and still fit the definition of this disease. 1/3 of people with the disease overall only have one echocardiographic segment that is noted to be thickened. So again, when you go looking for a patient with hypertrophic cardiomyopathy, what does that patient look like? What are they going to come in with that should put that as a diagnosis on your radar? And the answer is there are a lot of things, and it does not always look the same. They can come in looking like a heart failure patient, and a patient without, like, let's say, no previous diagnosis of heart failure, come in with dyspnea, orthopnea, paroxysmal nocturnal dyspnea, exertional intolerance. Particularly, these symptoms get exacerbated either in scenarios that accelerate heart rate, decrease preload, shorten the diastolic filling time, or increase the LV outflow tract obstruction. So exercise and immediate post-exercise recovery, as well as tachyarrhythmias will do this. Also exacerbated by conditions that worsen LV compliance, for example, ischemia. And probably worth noting, a big chunk of people, 5 to 10% of people with hypertrophic cardiomyopathy do progress to severe LV systolic dysfunction. So that's heart failure, but they can also come in looking like they're having an MI. And that happens in both obstructive and non-obstructive hypertrophic cardiomyopathy. Incidence of concomitant atherosclerosis, coronary artery disease, in hypertrophic cardiomyopathy patients is about 20%, so quite high. Basically, they develop intimal thickening of their larger coronary vessels, and they develop small vessel disease as well due to collagen deposition in the tissue. And contributing factors to why they have ischemia. So small vessel disease, as I mentioned, with a decreased vasodilatory capacity. Elevated myocardial wall tension. So, what that means is the difference between systemic diastolic blood pressure and LV end diastolic pressure is the perfusion pressure to the coronaries. And when you have very high LV end diastolic pressure and somewhat low because you're obstructing systemic diastolic pressure, it's kind of a two-hit to decrease coronary perfusing pressure. And then, well, that's what I just described. And then I think the most classic, maybe when you first learn about the disease, this is probably the canonical picture you think of, the young athlete who collapses in the field, which is a consequence of transiently diminished cerebral perfusion, or arrhythmia, really, and caused by inadequate cardiac output, usually in the context of exercise or in arrhythmia. And then finally, and maybe this is the more classic presentation you kind of naturally associate with hypertrophic cardiomyopathy, is sudden cardiac death. Certainly scary. The risk overall per year is lower than I think most people would think. It's less than 1% per year. But it is the most common cause of sudden cardiac death in children and young adults, people younger than 30. The risk diminishes with age, the yearly risk. And interestingly, 60%, around 60% of deaths from sudden cardiac deaths in patients with hypertrophic cardiomyopathy happen during periods of inactivity. Whereas, the remaining about, 40% occur during or immediately after vigorous physical exertion. Sudden cardiac death events are generally accepted to be due to sustained ventricular tachyarrhythmias. And this is caused by underlying myocardial disarray, fibrosis, silent ischemia associated with their microvascular coronary artery disease, and transiently really high sympathetic drive. When you obstruct and acutely drop your blood pressures, you get a sympathetic surge. So to recap, what does a hypertrophic cardiomyopathy patient actually look like? And the answer is they don't all fit a certain bill. They can look like kind of any of these things that we commonly see coming into the emergency department that cardiology is consulted for: heart failure exacerbation, ischemia, syncope, or death, status post, resuscitation. And kind of in the back of your mind, whenever you see that, should be, well, could the underlying disease be hypertrophic cardiomyopathy? Physical exam, I'm not going to belabor too much, but in short, with inspection, you can get an A wave, which indicates hypertrophy and lack of compliance of the right ventricle, a precordial heave, which represents the RV strain found in persons with concomitant pulmonary hypertension. You can feel the S4, kind of a third beat to every cardiac cycle, which comes from the late systolic bulge of the left ventricle. Something I think I feel like I've heard on test questions: bifid carotid pulse, which is caused by a hyperdynamic LV. So basically a brisk upstroke followed by a second impulse per cardiac cycle. And on auscultation, as I mentioned, you can hear that S4. You can also hear an S2 that is paradoxically split from prolonged ejection fraction, or ejection time rather, in patients with severe outflow tract obstruction. This murmur I'll talk about more on the next slide, but it's not the murmur of the LV outflow tract obstruction is not the only one you should be listening for. You should be listening for a mitral regurgitant murmur, as that's present in the majority of patients with obstructive disease, which is softer and more hollow systolic rather than crescendo decrescendo. And notably radiates to the axilla. And then just also be aware, 10% of people with obstructive disease also have aortic insufficiency. This is, I kind of made this PowerPoint as a way to just go back and look at almost as an alternative to a textbook chapter. This is something we've all seen a lot. And again, I'm not going to belabor it, but anything that increases preload or increases systemic vascular resistance will diminish the murmur you hear across the LVOT, because it essentially props the mitral valve and the septum further apart when your heart is more filled with blood or has to contract against more vascular resistance. And so that is the reason why certain maneuvers increase or decrease that particular murmur. And still something that I feel like has shown up on tests from step 1 to step 3, and I'll have to see about the cards boards. So talking about genetics of hypertrophic cardiomyopathy, again, I think there's maybe a misconception about hypertrophic cardiomyopathy that it is only an autosomal dominant disease, and there's a 50% chance that if your parent has it, you'll get it. The reality is it's a multigenic disease. The majority, I think, of cases are autosomal dominant. There are also some recessive mutations. It has incomplete penetrance, and it has variable expressivity. So incomplete penetrance being just because you inherit a gene for it doesn't mean you're going to express it at all. And variable expressivity means, two people can inherit the same gene, but have very different symptomatology and different severity of the disease. There are over 1,400 different mutations that have been recognized to contribute to hypertrophic cardiomyopathy in at least 11 genes. Culprit mutations are only found in half of the patients. In half, we never find a genetic explanation for their underlying hypertrophic cardiomyopathy. And then something I feel like maybe is a little bit of test fodder is the two genes most commonly associated with hypertrophic cardiomyopathy are mutated beta myosin heavy chain and myosin binding protein C. This is just to show you, they're both 15 to 25%, but somewhere in between, really the majority of cases are these very infrequent mutations or just mutations that we haven't identified yet. So for genetics, when it comes to hypertrophic cardiomyopathy, I know this is clearly like an overwhelming amount of text to read, right? But to highlight the two things I have boxed in red, if you have a patient with hypertrophic cardiomyopathy confirmed, you should genetically test them and use, for the sake of then using that to screen their children if they have children. You shouldn't screen the children of people with hypertrophic cardiomyopathy with a panel of gene mutations if you don't know what the underlying gene mutation in the parent was. So let's talk about diagnostic testing for hypertrophic cardiomyopathy. Always start with an EKG. An EKG is just another one of the vitals, right? Most patients will have an abnormal EKG if they have hypertrophic cardiomyopathy, but there is really no canonical or like pathognomonic one finding, that you'll see in all of these patients. Look for inferior or inferolateral Q waves, as the patient I showed you a patient example earlier had. Left axis deviation, a slurred shortened PR interval, and then more specifically, if you have Yamaguchi or apical hypertrophic cardiomyopathy, so hypertrophy isolated only to the apex of the LV, a somewhat actually pathognomonic finding are these really large negative precordial T waves. Yamaguchi hypertrophic cardiomyopathy is about 25% of the cases in Japan, but worldwide about less than 1% of cases. So transthoracic echo, using two-dimensional and M mode, you want to look for a few defining features. And, this is really what I guess turns us on to the diagnosis initially of hypertrophic cardiomyopathies when you put a probe up to their chest and you see the hypertrophy. Look for a maximum LV diastolic wall thickness of 1.5 centimeters. Most commonly pretty asymmetric, as opposed to, let's say, findings of longstanding systemic hypertension being more concentric and uniform. Systolic anterior motion of the mitral valve. So again, that anterior leaflet of the mitral valve getting kind of sucked into the left ventricular outflow tract, kind of slamming up against the interventricular septum, creating that obstruction. A small LV cavity. A resting gradient greater than 30 across the LVOT, or a provocable gradient greater than 50. Our patient had both, right? Her resting gradient was 40-something, 44, and her provocable gradient was like an almost unrealistically high number of like 170. Now with Doppler echo, where you can look at those pressure gradients, about 1/4 of patients who end up getting a diagnosis of hypertrophic cardiomyopathy will actually have an elevated resting LVOT pressure gradient. And so that's, I guess, less than I would think. But half of the people who don't have that elevated resting gradient will still have an elevated provocable gradient or inducible gradient. And okay, so what does it mean to induce a gradient? So, okay, you have your probe up against the patient's chest and you have Doppler across the LVOT, and you get a gradient of like 20, not 30, not enough to qualify technically, but it's a pretty big septum, and you feel like you see the like systolic anterior motion of the mitral valve. And so you think that there is obstructive disease, even though you can't prove it with resting. You do a few maneuvers. So as I mentioned before, things that decrease preload to the LV will worsen the murmur of hypertrophic cardiomyopathy. And in the same vein, they will increase the pressure gradient across the valve because you get more obstruction. And so to do that, Valsalva maneuver or amyl nitrite are kind of the two, I think, classic ways to induce obstruction. Traditionally, I think dobutamine was also used, but it is recommended against. It can provoke an increased gradient in normal patients, aka false positives. So it's not thought to have much diagnostic value. So diagnosis of hypertrophic cardiomyopathy with obstruction, which is probably a less contentious way to say that than HOCM or hypertrophic obstructive cardiomyopathy, a term we're trying to kind of phase out. That formal term is based on an elevated resting instantaneous gradient. And the degree of that resting gradient, like, so how much obstruction there is related to the amount of time the mitral valve spends kind of in systolic anterior motion, pressed up against the interventricular septum and occluding blood flow through the LVOT. So I said, okay, really people with resting gradient should be called, elevated resting gradient should be called hypertrophic cardiomyopathy with obstruction. So what do you call these people with provocable gradients? And I think I've seen the term quite a lot in while preparing for this, hypertrophic cardiomyopathy with latent obstruction, or perhaps just hypertrophic cardiomyopathy with inducible obstruction. The last thing you really want to pay attention to on Doppler echo is the mitral valve. There's mitral valve disease in the majority of patients with hypertrophic cardiomyopathy, structural disease, that is. So an increased leaflet area, elongated leaflets, elongated chordae, and anomalous papillary muscle insertion directly into the anterior mitral leaflet. All of these, I think, are considered to be a consequence of just the mitral valve kind of constantly being sucked out of coaptation into the LVOT. And even when there is no structural mitral valve disease, like even if the mitral valve actually looks normal, mitral regurg probably is still happening if you have obstructive hypertrophic cardiomyopathy. The severity of it will correlate with the a degree of obstruction of the LVOT. In other words, again, the amount of time that mitral valve spends in systolic anterior motion. And then to round up talking about echoes for diagnosis of these patients. So let's say that you try a resting echo and you can't prove that there's a gradient to qualify for obstructive disease across the LVOT. Then you try provoking them with both Valsalva and with amyl nitrite, and you still can't reach that threshold, but it just looks like there's obstruction happening. And maybe you're just not capturing it because who knows, you can't get a great angle with your probe. And so stress echo is actually pretty helpful in these scenarios. It not only, obviously quantifies the patient's functional capacity, but it can determine the presence of an obstruction in really a more physiologic condition than these, giving amyl nitrate, for example. It also has value in terms of prognostication, observing how the blood pressure, heart rate, and rhythm change in response to increasing intensity of exercise. Again, really overwhelming amount of text, but just to summarize the 4 boxes that I thought were probably the most important, in short, start with a transthoracic echo. If you can't prove obstruction, do provocative maneuvers. If provocative maneuvers can't prove obstruction, but you still think it's there, do an exercise echocardiogram. And for people with confirmed diagnosis of hypertrophic cardiomyopathy, repeat this echo every 1 to 2 years. Other diagnostic modality. So cardiac MRI. This can be used to detect left ventricular hypertrophy missed by echo, specifically in kind of non-typical locations of this hypertrophy, such as the anterolateral or basal LV free walls. It can also be used to detect myocardial scar by delayed gadolinium contrast enhancement, which is actually a finding very common in hypertrophic cardiomyopathy, and is a little bit like under research now, a little unclear how this would actually guide us, but the amount of hyperenhancement you see may be a predictor of sudden cardiac death in hypertrophic cardiomyopathy patients. And then also it can differentiate alternative causes. So if you see, a thickened LV, it doesn't mean it's necessarily automatically hypertrophic cardiomyopathy. It could represent an infiltrative process such as amyloidosis or Fabry disease. So again, in short, if the echo is inconclusive for hypertrophy, but you think it's there, get an MRI, especially if you suspect a disease that mimics hypertrophic cardiomyopathy, such as infiltrative disease. And finally, for diagnostic testing is cardiac catheterization. So this is most often it takes place really in the setting of working a patient up prior to considering a septal myectomy. before you open up their chest, you want to know their coronary anatomy to know if they need a simultaneous bypass surgery, right? This will happen in the setting of a patient who comes in with, yes, hypertrophic cardiomyopathy, but really predominant ischemic symptoms, chest pain, elevated troponins, EKG changes. Interestingly, so as I mentioned, about 20% of patients with hypertrophic cardiomyopathy do have atherosclerotic coronary artery disease. However, even if you don't have atherosclerosis, you can still have coronary artery disease, if you want to define it that way, in the form of myocardial bridging. So your coronary is diving under the ever expanding LV myocardium and getting essentially pinched. Reduced coronary flow reserve, particularly with microvascular disease, and systolic reversal flow in the coronaries. The cardiac catheterization is also used for hemodynamic assessment in patients with hypertrophic cardiomyopathy without obstruction captured by non-invasive imaging. As I mentioned, I mentioned several steps you take to try to prove obstruction if you think it's happening. But if you just put your catheter probe, essentially throughout the LV and out the LVOT, you can actually directly measure the pressure gradients there. And then finally, a ventriculogram, just injecting dye while you're in the left ventricle can better define the LV cavity anatomy and help localize focal areas of hypertrophy. I included this, again, because I kind of wanted this PowerPoint to be a thing that you can just open back up as an alternative to like a chapter in a textbook on hypertrophic cardiomyopathy. I included this because I feel like I've already been like pimped on this a few times in my short time in fellowship so far in the cath lab, which is the Brockenbrough-Braunwald-Morrow sign. Basically, if you're looking at the aortic pressure and the LV pressure tracings, and you happen to have a PVC, an early ventricular contraction, you have a compensatory pause after that PVC. But because so much more volume has been able to build up in the LV in this kind of protracted time filling, you get a much higher pressure waveform on the subsequent beat. These are other findings. I think to not put you to sleep, I'm going to skip over a few bullet points. So when it comes to angiogram and invasive hemodynamic assessment, just note that for people who are candidates for septal myectomy or septal reduction surgery, you should get a coronary angiogram. And you can simultaneously use that left heart catheterization for assessment of degree of LV outflow tract obstruction. And then if they have ischemic symptoms, then coronary angiogram can work. Although, if you're just looking for that, a CT coronary angiogram is an equally, I think, valid and also non-invasive method. So let's talk about, we just spent a while talking about how you actually make the diagnosis of hypertrophic cardiomyopathy, but let's talk about what you do once you've made that diagnosis. There are two goals in disease management in terms of pharmacotherapy. One is symptom management. And really what this means to an individual may be different from one person to the next, kind of depending on what their predominant symptoms are. That, of course, being, as I mentioned before, heart failure, arrhythmia, ischemia, I said arrhythmia twice, obstruction, mitral regurgitation. And then the second goal being preventing sudden cardiac death. So the next 4 slides are going to be pharmacotherapy. And this one really comes up top. The first line therapy for hypertrophic cardiomyopathy is beta blockade for both obstructive and non-obstructive. Beta blockers have been shown to improve symptoms of hypertrophic cardiomyopathy and increase exercise tolerance. haven't been demonstrated in any large RCT to decrease mortality, at least not yet. And the benefit is not well established in patients who are both asymptomatic and don't have obstructive disease, just have hypertrophic cardiomyopathy. I put an asterisk by this last point because it seems like it was more emphasized in the 2014 guidelines than it is in the updated 2020 guidelines. But I think it may still affect people's practice a lot. Cardioselective beta blockers are considered preferable in, or at least they were, in hypertrophic cardiomyopathy over non-selective alpha beta blockers to avoid the excess peripheral vasodilation. Again, somewhat of a higher systemic vascular resistance helps prevent LVOT obstruction. So the concern is if you excessively peripherally vasodilate them, it can actually worsen the obstruction. What is still considered technically first line in terms of like degree of evidence and magnitude of recommendation is a 9-dihydropyridine calcium channel blocker. But I would say it's more of a second line drug, either if you can't use beta blockers because they're intolerant, or if you aren't getting an adequate response with beta blockers alone. They may improve diastolic function by improving rapid diastolic filling, but also this comes at the expense of maybe causing higher left ventricular end diastolic pressure. Also, kind of a reason to be cautious with them. Same as before, where you'd preferably not use an alpha beta blocker. Even non-dihydropyridine calcium channel blockers can have pretty profound peripheral vasodilatory effect, and so titrate cautiously if you're introducing these medications. Disopyramide kind of comes after both of the beta blocker and calcium channel blockers. It is a class 1A antiarrhythmic, which is to say a sodium channel blocker. And it can be used as an alternative or an adjunct to beta blockade or calcium channel blocker. It has real strong negative inotropic properties and also the ability to suppress both atrial and ventricular arrhythmias. But there are a few disadvantages to using it. So it can augment AV conduction. So if you're already in atrial fibrillation, it can actually worsen RVR. It accumulates in patients with hepatic and renal injury. And it has pretty strong anticholinergic side effects. But another reason to not use it is it has, at least as a long-term therapy, is it has a kind of diminishing hemodynamic effect with time. So the context in which it is used most is probably as a temporary bridge to more definitive management, such as a surgical myectomy or alcohol septal ablation, if you aren't able to get there alone with beta blockade or calcium channel blocker. ACEs and ARBs historically have been avoided to avoid peripheral vasodilation, but really just the jury's out when it comes to using them. There was a trial that took place like a year ago, like 3 years ago, I think, the Inherit trial that looked at losartan versus placebo in slowing progression of disease, and there was no difference seen between both groups, Diuretics. So use very cautiously. These patients, again, like to have very well-filled left ventricles, and so over-diuresis can reduce LV size and increase obstructive physiology. Digoxin is generally avoided because of worsening LVOT obstruction secondary to its positive inotropic effect. Although this is not an evidence-guided practice, it kind of makes physiologic sense. And then finally, to mention is phenylephrine. So as I mentioned, talking about my first case at the beginning of this presentation, she was started on phenylephrine for blood pressure support when she was in shock. And that's, not commonly a first line vasopressor, but it is for these patients. To avoid inotropy from beta agonism and to just have selective alpha agonism peripherally. So this is what I would start a patient like her on first. This is all, in short, use beta blockers followed by calcium channel blockers followed by disopyramide. and give fluids. And if fluids don't work in shock, then give phenylephrine first. So let's get back to our patient. It's been a while, sorry. So she was started on metoprolol succinate after the phenylephrine was weaned off, and it was up titrated to a pretty hefty, good dose. Heart rate, good, 55 to 70. And her lisinopril was discontinued. Blood pressures remained pretty good for the remainder of the hospitalization. She underwent dual chamber pacemaker placement, the indications for which I'll talk about in a bit, and had no more events during the 10-day hospitalization. So she was discharged home. However, 3 weeks later, she came back with essentially the same presentation. So our question should be, she's on a pretty good medication regimen, but still pretty profoundly symptomatic, similar to, ICU admission this time around. So what should our next step be? And really the next step is to consider invasive management. Septal myectomy, or literally cutting out part of the septum, the beefy part of the septum, is really the treatment of choice for these patients. It's been performed for more than 50 years, and it's indicated for patients with symptomatic hypertrophic cardiomyopathy, obstructive hypertrophic cardiomyopathy, in patients despite maximum medical therapy. It's the most definitive treatment, and it really the surgery itself, if practiced by an experienced surgeon, carries a mortality risk of between less than 1% to 2%. So quite low in an otherwise very sick patient who probably needs this surgery. The surgery is shown to improve symptoms, improve resting LVOT gradients, improve mitral regurgitation alone, even without mitral valve repair, and improve filling pressures. After the myectomy, survival is actually comparable in these hypertrophic cardiomyopathy patients to the general population. The other benefit of pursuing surgery as opposed to an endovascular procedure is that you can address concomitant conditions. So if the patient, as I mentioned, has an abnormal papillary muscle attachment to the mitral valve, has mitral valve disease that you don't think is going to respond to just the myectomy alone, or has atrial fibrillation and could undergo a Mays procedure to reduce or eliminate arrhythmia burden, that would be another reason to consider surgery first. The alternative to surgical septal myectomy is alcohol septal ablation. It's essentially described as a controlled infarction. Basically, we're giving them an MI selectively of blood vessels perfusing the septum. It's an alternative to surgical myectomy in patients who are not surgical candidates. There have been no randomized controlled trials comparing surgical myectomy to alcohol ablation. The technique is interesting. So you use a guide wire to go into the left main and into the first or second septal perforator, or both. Use an angioplasty catheter to occlude upstream of the vessel you're going to ablate, and then use contrast to make sure that you formed that seal, and then inject 1 to 4 mils of essentially Everclear pure alcohol. It also uses a temporary transvenous pacer to prevent transient or treat transient conduction abnormalities. Here's a picture of the guide wire being advanced into the first septal perforator here, coming off of the LAD, and then alcohol is injected. Patients have a triphasic response to this therapy. So immediately, like within minutes, there is a decrease in LVOT gradient and symptomatic improvement really within like hours, minutes to hours. And this is due to myocardial stunning from essentially just having taken a shot. You do get early reappearance of some LVOT gradient, but symptoms may actually remain improved. And that's as it just recovers from myocardial stunning. And then you get finally a sustained fall in LVOT gradient by around 3 months post-procedure due to the remodeling and myocardial septal thinning. The risks, though, are pretty real. So you can induce a high-grade AV block, as you can imagine, when you're injecting into the part of the heart that carries the biggest conduction system to both ventricles. You can get a coronary dissection, as always. You can develop a large anterior wall infarct, particularly if you inject outside of the vessel you were targeting, or if that vessel actually supplies, other parts of the myocardium. And then you can have electrical instability from the resultant scar. Again, you are essentially giving this patient a selective MI, but you will have a scar likely as a result of that, and that can be arrhythmogenic. A lot of text, but to summarize really quickly, if there are symptoms despite pharmacotherapy, do septal surgery, septal reduction surgery. If surgery is not an option, consider alcohol ablation. So our patient underwent septal myectomy. She was a 59-year-old lady who was in excellent health. She was a perfect surgical candidate. So that was really the preferred procedure. And this is her post. You do see a reduction in her interventricular septal diameter, but I think more impressively is you see a Valsalva pressure gradient in this late. I mean, before it was reading as what, 170 something, reading is just 6, which is almost unbelievable. Maybe that's the result partially of the angle of the probe, but still a really vast improvement. She also symptomatically did great after this. So that was a lot of kind of the, I guess, bread and butter hypertrophic cardiomyopathy. But I want to talk about special considerations, special cases now. And the first is atrial fibrillation, which occurs in like 1/3 of patients with hypertrophic cardiomyopathy, very prevalent. As you can imagine, patients with dilated atria and myocardial scarring, of course, it's common. So with atrial fibrillation, you get loss of atrial kick and you get decreased diastolic filling time because, generally speaking, you're more tachycardic. And both of these can, decrease volume in the LV and therefore contribute to obstruction. So if a patient pops into AFib and out, or has paroxysmal AFib and becomes, it's not unreasonable that they become profoundly symptomatic when they're in it, and then it resolves when they're not in AFib. And in these patients, you really want to either rhythm control them. Amiodarone is one of the only medications that has been studied. Medications like dofetilide, sotalol, dronedarone, kind of those other antiarrhythmics we use for AFib, are not well studied in hypertrophic cardiomyopathy publications. Oh. Well, I got a message that says my session has expired.
You're all set. Keep going right on.
Okay, sorry. Oh, Zoom. Give me a second to re-enter the presentation. Okay. For people who have persistent AFib but do tolerate the AFib well and can be rate controlled, rate control is not an unreasonable strategy. You're probably giving these patients beta blockers anyway. The final thing, and this is, I think, probably the most important thing I mentioned, is that you really don't look to a CHA2DS2-VASc score in patients with hypertrophic cardiomyopathy to determine if you should anticoagulate or not. Their risk is intrinsically very high, regardless of what this score will be. And so you should anticoagulate. And actually, I find it kind of interesting. ACC recommends DOACs over warfarin for this particular population, which, I mean, I'm on board with. Summary of what I just said. The next thing is consideration of an ICD for these patients. So you want to stratify their risk of, ventricular tachyarrhythmia. An ICD is strongly recommended if they've already had a cardiac arrest or if they've been in sustained VT. The annual rate of appropriate ICD discharges in this population for sustained ventricular tachyarrhythmia, I actually wrote the wrong number here. I apologize. It's not 4%, it's 10. So, in 10 years, you will probably get one shock, if you want to think about it that way, if you got an ICD for primary prevention in the context of hypertrophic cardiomyopathy. For secondary prevention, sorry. For primary prevention, it's a little bit more, it's actually one of the more challenging aspects of managing hypertrophic cardiomyopathy, and requires shared decision-making. I'm going to show you on the next slide what constitutes like indications for primary prevention ICD, in patients who have not arrested or not had sustained VT. Because, and here's why, the frequency of annual ICD-related complications, so infection and inappropriate discharges in hypertrophic cardiomyopathy, is 4%. But the annual rate for appropriate ICD discharges, so appropriate discharge to get you out of a sustained ventricular tachyarrhythmia, is also roughly 4%. And so wherein is the benefit and the risk? What side do you lean more in favor of? And it is determined by these risk factors largely here. So established risk markers for primary prevention, an indication for primary prevention ICD. And that's prolonged repetitive episodes of non-sustained ventricular tachycardia, particularly thick LV wall, a family history of sudden cardiac death in the first degree relative, failure of blood pressure to augment with exercise, and syncope without any other attributable cause. I will mention, although I don't have it written here, that the ACC website has a calculator for your risk of ventricular tachyarrhythmia, where you enter information like this. And so the number that it gives you can help guide you, if there's a 4% risk of inappropriate discharge or infection, but there's an 8% risk for this particular high-risk patient, then maybe it's worthwhile to put an ICD in these patients. But like I said, it's kind of one of the more challenging aspects of managing hypertrophic cardiomyopathy patients. I'm gonna end with a second case and one more kind of special consideration. Second case is a 21-year-old male soccer player who came to the ED for syncope in the field. Sound familiar, right? But he was hyperthermic in the ED, and that's what they thought was the cause of the syncope. He recovered well after his temperature normalized, and he was referred as an add-on next day appointment to our cardiology clinic for further workup of syncope. Prior to the appointment, like right before, he got a transthoracic echo, and this demonstrated some focal apical septal thickness of 14 millimeters, no systolic anterior motion, no LV outflow tract obstruction. So the question becomes, how do you differentiate the pathology that is hypertrophic cardiomyopathy from an athlete's heart? Athletes' hearts are known to hypertrophy in response to like high intensity training. So how do we parse those two out? This is his initial echo. And you can see the kind of almost focally, the apical septum does look a bit thickened. So let's go over a few characteristics that would point you in one direction or the other. Characteristics that point you towards hypertrophic cardiomyopathy, pathology, are unusual patterns of hypertrophy. Usually athletes' hearts will hypertrophy in a concentric fashion, not focally. LV in diastolic diameter of less than 45 millimeters. So basically their LV does not fill up with a lot of fluid. Septal thickening greater than 15 millimeters. His was 14. LA enlargement, diastolic dysfunction, and of course, a family history of hypertrophic cardiomyopathy or sudden cardiac death. By contrast, an athlete's heart, athletic hypertrophy of the myocardium, if you will, is more suspected when the LV in diastolic diameter, or in other words, the fluid filling up the LV, is greater than 45 millimeters. There is septal thickening, but it is less than 15 millimeters. The left atrial size is not particularly enlarged, and there's a decrease in LV thickness with deconditioning. So this is known as an off-season echo finding, where previously hypertrophied ventricle when a patient is off season and not training regularly shrinks back down. If you have trouble differentiating the two, when it's not an absolutely clear-cut case, you can do an invasive cardiopulmonary exercise test, which can further help distinguish between the two. The peak oxygen consumption being greater than 50 mils per kg per minute or greater than 120% predicted is highly suggestive of an athlete's heart, basically an elite athlete who has gone through a lot of intensity training, not hypertrophic cardiomyopathy, which is generally below the predicted threshold. And should differentiation still not be possible, what we should do is tell our patient to stop exercising, stop training, and over several months follow him up with echo. So back to this patient, his LA is mildly enlarged, but otherwise normal diastolic parameters, and his LV in diastolic diameter is larger, is adequate rather, 50 millimeters. Got an invasive CPET on him, and he tolerated it well. He did have a good oxygen VO2, 110% predicted max, not quite that most reassuring threshold of 120. And so it was unclear. Did this patient syncopize due to hyperthermia, or is he having symptomatic obstruction that we're just not able to pick up? And so we requested that the patient stop training for around 4 months and repeat an echo, which is obviously a really sad thing to ask somebody who really values their athleticism to do, but we didn't think it was safe. The repeat echo demonstrated apical septal thickness of 15 millimeters. So even perhaps maybe a little bit larger than before, and persistence of mild LA enlargement, no other changes. He would really like to return to soccer. And what would you recommend next? Going over a few images. So you can see persistence of thickened septum. We ended up, to the answer, what would we do next? We ended up getting an exercise stress echo. So I know this is kind of small, but so, here's his LVOT pressure gradient at rest and when he Valsalva'd, both of which were not impressive. It's like 12 and 18. Remember, we're looking for a threshold of 30 or 50. But we got him to exercise, and we got his pressure gradient up to 100, which is really profound. And keep in mind, when he's exercising, I mean, that's more realistic to his day-to-day life as an athlete. And so, we were content, especially because he had repeat symptoms, to call him hypertrophic cardiomyopathy. He was started on mavacamten. That's not something I talked about earlier in this presentation. It's a newer medication that's used to reduce myocardial fibrosis and decrease myocardial size, essentially decrease the pressure gradient and obstructive physiology. New medication. He was started on it, and then actually the dose was titrated with every few month repeat exercise stress echoes, where we would again measure his pressure gradient at peak performance, and we saw it come down pretty impressively. So this is his peak exercise his pressure gradient after about a year of being a little less of being on mavacamten, and it's come down to 24 from 100, which is really impressive. Makes me excited to see kind of, this drug be used more. So for participation in sports, what if you have a hypertrophic cardiomyopathy patient and they want to go back to competing? You can't force them not to, right? So, it's the most common cause of sudden death in young athletes. Athletes, really the recommendation is then athletes with hypertrophic cardiomyopathy with or without obstruction who are less than 30 years old should not participate in competitive, high intensity or medium intensity sports. And interestingly, these recommendations kind of remain in place whether you undergo surgical myectomy or not. I guess the thought is if it hypertrophied once, probably not helped by the exercise, it may do it again. However, mild to moderate intensity recreational exercise, sports, so not competitive level, but recreational, is actually encouraged for these patients in the same way that it's encouraged for the general population to improve cardiorespiratory fitness, physical functioning, and quality of life. Here are those recommendations summed up. And finally, and I'm sorry that 2 minutes over time, the end. So, and here are my sources. So what questions can I at least attempt to answer for people?
Yeah, for everyone in the audience, please feel free to use the question and answer function or the chat function. We'll see them either way. Well, while you're thinking about your questions or writing them up, I'll take just a brief moment to, of course, tell you about a couple future offerings we have for you. If you want to join us later this week, we've got the Fellows Symposium, Networking and the Job Search. We'll have a full panel for you to have a roundtable discussion about that job search and networking with some prominent cardiologists in the region. So feel free to sign up for that. Happy to have you. And then we're very excited to announce the next 2 talks in our lecture series. So on the second Tuesday of December, the 13th, we have Dr. Vikram Sharma from the University of Iowa talking about structural echo. And then on January 10th, we're going to welcome Dr. Deepak Paspula with Mercy Health talking about left atrial appendage occlusion devices and echo. So get excited for those. Hopefully you can join us for the rest of our recurring series. And it doesn't look like we have any questions, Dr. Parker. We've just got a lot of really nice comments.
I think I talked way too much.
No, I think you talked the perfect amount. Thanks everyone for tuning in.
Yeah. Thank you so much, everybody. I appreciate your time.
Yeah, absolutely. Well, we hope to see you at some future events. And thanks again to Dr. Parker.
All right.